Hi, and welcome to my seminar on weight loss surgery and the various aspects and procedures involved. I use this session not as a sales pitch. I use this as an educational forum. My goal is to teach you about what the different options are, and it's up to you to decide whether the surgery is right for you or maybe not. There are various different procedures that are right for different individuals. I'm going to give you a little bit of a foundation into what these different procedures are and why you might choose one over the other. My name is Jonathan Aranow. I've been performing weight loss surgery here at Middlesex since around 2001. I actually came on board here in 1999. I did all my training in Boston at the Beth Israel Deaconess Medical Center and the Harvard Medical School program. And that's where I learned how to do bariatric surgery, but I have continued my education, and I have been learning new techniques and developing my old techniques for the last two decades. The program here I started in 2001, and back in those days it was open gastric bypass. Nowadays it's robots and sleeves and various new techniques. So the program has really developed over the time. I do have another surgeon in the program. You may hear his name occasionally. It's Dr. Klimovich, and he does have a seminar of his own. Since starting the program in 2001, we have adopted the most effective safety behaviors that we can. We have got an excellent QI program where we're always looking at making our program better. And because of that, we were one of the first programs in the country recognized as a center of excellence, and one of the first programs accredited by the American College of Surgeons as what's called a Level 1 comprehensive care center. Our program is a multidisciplinary program where we involve not just surgeons and dietitians. There's also behavioral counseling, physical therapy. Nursing is very closely involved. Everything from the physical plan to making sure we have the right size gowns, to the right size chairs, to the right size beds, is designed to treat our patients just as we would any other patient with dignity and respect. One of the key features of our program is we are not just a surgical program. We are integrated into a medical weight loss program as well. And that kind of grew from our surgical program where, surgery is a treatment for morbid obesity, but it's not the only treatment. This is a complex disease. So in somebody who has resistant disease, they may need more additional treatments other than just surgery. And we developed a post-procedure program that supports medical care. So whether it be pharmaceutical care to give additional appetite suppression, or whether it's additional behavioral counseling or dietary counseling, that was integral to our surgical program. And from that, we've developed a medical weight loss program as well. And these two programs work hand in hand to help get the best results that a surgical procedure can get. And we can give the additional supportive care after surgery to really optimize results. So that's kind of a unique feature of the Middlesex Health Program, is this integrated medical weight loss program where we're not just doing surgery and sending you on your way. We aim for a lifelong support system to really optimize your results. Personally, I do about 150 weight loss procedures a year. My particular practice is somewhat unique here at this hospital and actually in the state. I focus only on stomach and esophageal surgery. So half my practice is weight loss surgery and about 150 weight loss procedures a year. And the other half of my practice is surgery for heartburn, reflux, hiatal hernias, that kind of procedure. Having been doing this surgery for the last 20 some odd years, I've got a lot of practice. And this is not a teaching hospital. So when you have surgery with me, I am your surgeon. I do your surgery. I see you in the pre-op. I see you in the post-op. I determine beforehand, are you a good candidate? And what kind of surgeries should we pursue? And we work on that together. So there's a dialogue between the patient and myself about deciding, should we move forward with surgery and what surgery to perform? I do the surgery and I do the post-op care. So immediately after surgery, if there's any problems, any complications, those phone calls come to me. You will hear from me. There's no residents, there's no fellows learning how to do this operation. In the long term, I do have my medical weight loss team. Dana Cantiello is my nurse practitioner. And after we get about 6 months out after surgery, where things are stable, and if you have no kind of any kind of problems related to the surgery, I'll transition the care over to Dana for monitoring labs, monitoring the weight, making sure that medications and health status progress with the surgical weight loss. Because I'm so directly involved with this, and because I've done so many of these surgeries, over 3,000 weight loss procedures in my career, it really is translated to some of the lowest complications, not just in Connecticut, but nationally. And we are, as a part of the American College of Surgeons, we are involved in a database where we monitor our outcomes, compare them to national standards, and make sure that we are at least as good as, if not always striving for, better than the rest of the other programs in this state and in this country. So that's a little bit about me. I'll talk a little bit more about the program and how one progresses through the program towards the end of the talk. I'm going to focus a little bit more now on the actual disease of morbid obesity, and it is indeed a disease. My philosophy when it comes to treating morbid obesity is just like treating high blood pressure, treating diabetes. High blood pressure, diabetes, primary care physicians see it all the time. And what they do, what's the first line of treatment for high blood pressure, diabetes? Change your diet, exercise more, behavioral modification. The interesting thing is with high blood pressure and diabetes, there's no stigma. So when the patient comes back after a month, 2 months, 6 months, and their high blood pressure is worse or their diabetes is worse, they're not chastised for not following the proper diet. They're put on medications and treated for those diseases. Obesity isn't treated the same way. And obesity is a cause of high blood pressure and diabetes. When somebody is told you need to eat better, and they come back and the primary care says, well, you haven't been sticking to the diet, you haven't been exercising, your weight's going up. Well, that's all your responsibility. It shouldn't be your responsibility. It is your health. Your health is always your responsibility, but the underlying disease, you should be able to have your primary care join you in that fight. There are other treatments. There are medications. There are many appetite suppressant medications that work very effectively for obesity. And if those modalities were integrated into your healthcare earlier, we might not have to talk about surgery. Unfortunately, morbid obesity is the extreme. And it's from lifelong, very often lifelong progression of a chronic illness. So when it comes to our medical therapy patients, we treat them as we would anybody with high blood pressure, diabetes. We try behavioral counseling, and if they're doing well, we'll work on that. We will perform an integrated, intensive program, twice a month contacts, where how are you doing, giving that verbal support. And if we're not accomplishing our goals and losing weight, we have those patients start on appetite suppressant medications. And there's a host of different medications we can try. Now, when we see patients who are coming into us who already have health that's been compromised by their weight, or weight that is 100 pounds or more over where their ideal weight is, medications, diet, the cat's, out of the house. We have to control that in a more aggressive fashion, and that's where surgery steps in. And morbid obesity, the word morbid means you're sick because you're heavy. So that weight has caused additional disease. And once you reach a point where that weight is causing illness, we need to be more aggressive about the care. Some of the things that we're going to see from this level of obesity, almost all my patients have some sort of respiratory illness. All that weight sitting on your belly, pushing up on your diaphragm, sitting on your chest, pushing down on your lungs. It means you can't take a good deep breath. That's called restrictive lung disease. And the symptoms, you walk up a flight of stairs and you have to take a lot of rapid breaths to compensate for that one deep breath. Your body just can't perform because of all that weight pushing down on the lungs. So almost everybody that I see, that I take care of for surgical weight loss has some element of restrictive lung disease. And that compromises your ability to exercise and lose weight, and it's a catch-22. That extra weight can sit in the airways and in the tubes that exchange air to the lungs. And narrow airways can cause simple things like snoring. Snoring so bad that your airway closes up completely during the night, that's sleep apnea. You may not know you have sleep apnea, but if you're tired all the time, I hear people all the time saying to me, Doc, I'm so tired because I'm heavy. Well, very often they have undiagnosed sleep apnea. They never get a good sleep because every time they go into a deep sleep, the airway closes up, they snore and snort themselves awake. They may not wake up completely, so they don't know that that's happening. And that's what sleep apnea does. It keeps somebody from having a good night's sleep, but also starves their body of oxygen during the night and can cause cardiac problems, pulmonary hypertension, and it can also cause car accidents because you're not sleeping well. In addition to that, those airways can be narrow and reactive to allergens, and that's what asthma very often is from. So a lot of our patients will have asthma, sleep apnea, and restrictive lung disease. And all these things are reversible with just weight loss. Diabetes is present in about 20% of our patients, and fatty tissues are hormonally active. And one of the things those hormones will do is confer resistance to insulin. So many patients, even if they're not diabetic, we screen their insulin levels are through the roof because they have to be high to combat the insulin resistance that's engendered by the fatty tissue. And again, with weight loss will come improvements in diabetes. Interestingly though, surgical weight loss, by rerouting how nutrients are absorbed, we can even change how your body releases insulin and responds to insulin. And some of the procedures that I'm going to talk about have cure rates for diabetes of 85%. That's an 85% cure for diabetes. And how quick does that occur? Almost overnight. So we're not just talking about surgery to reduce weight, we're talking about metabolic surgery to change how your body responds to sugars and nutrients. So we call this metabolic surgery, not just weight loss surgery. High blood pressure is present in about half of our patients. High cholesterol, again, almost half of our patients. And you put diabetes and high blood pressure and cholesterol together, as many as 10% of our patients have had a heart attack or have silent heart disease or have coronary artery disease. All this adds up. I've had patients going through a 6-month pre-op process. Their insurance has required them to go through 6 months of pre-op process. I've had patients have heart attacks just waiting for their surgery. Now, ideally, we are intervening before the coronary disease is lethal, but I've seen people just waiting for surgery or considering surgery have heart attacks that maybe we could have prevented by doing a surgery a year earlier. All that weight sitting on your knees, your hips, your joints, the cartilage rubs down, runs out. We get degenerative joint disease, osteoarthritis. I see a large number of patients referred to me by orthopedists because once we're in that morbidly obese range, orthopedists aren't going to do joint replacements. Knee replacements, hip replacements carry 40 to 80 times higher risks of complications when performed in somebody with the level of obesity that we're talking about here. That extra weight sitting on your bladder, if you've complained to your doctor, hey doc, ever since I had the kids, I wet myself. And your doctor says, well, you've had a few kids, you're a little overweight, that's kind of normal. That's not normal. And if we can get that weight off your bladder, most of our patients with incontinence will get rid of their incontinence. Irregular periods, polycystic ovary disease, infertility, that again relates to the hormonal effects of obesity. And if we can get rid of the weight, we can get rid of those testosterone-type hormones that are circulating and combating normal menstrual cycles, infertility. And I can tell you, I've had a lot of patients who've struggled with infertility, unable to conceive, and against my advice, were pregnant within months of having their surgery. Is it safe to have a child after one of these weight loss procedures? Absolutely. If the average weight is 340 pounds of a patient coming to see me, and then a year later they're 180 pounds, what do you think is a safer pregnancy, 340 or 180? So we do improve pregnancy and birth safety. The only rule is you don't want to get pregnant in that 1 year of rapid weight loss. And that's how quickly the weight loss occurs, is within about a year for most of these procedures. So while the weight is rapidly descending, we do recommend 2 forms of birth control. IUDs are the most reliable. Oral birth controls you do need to be careful about because the absorption can change, and higher dose estrogen-containing birth control pills are necessary. You need to talk about that with your obstetrician gynecologist. Having said that, I do make a rule of no estrogen-containing birth control for a month before surgery and a month after surgery because of the elevated risk of blood clots. So you need to talk with your caregivers about alternate forms of birth control. And again, I recommend 2 forms of birth control, one of them usually being barrier protection. I can tell you without a doubt, abstinence doesn't work. People become a lot more sexually active as they start losing weight and start feeling better about themselves. So again, 2 forms of birth control. We do not want to have a pregnancy during that first year after surgery. Additional risk from the obesity? Well, you know, I've heard people say, you know, doc, it's not like you're fighting cancer. Well, we are. The incidence of cancer goes up 33 to 55% higher chance of dying from cancer if you're morbidly obese. The risk of developing prostate cancer, uterine cancer, ovarian cancer, breast cancer, colon cancer goes up almost double. Pancreatic cancer goes up almost 4-fold in somebody with morbid obesity. And if we can change your weight and get you down to a healthier weight, we could potentially reduce those cancer risks. And not only are those cancer risks higher, those cancers are more lethal. They're diagnosed later, and the treatments are more limited because of the weight. So we are fighting cancer here. There's a 40% higher chance of having a heart attack. Major cardiac death goes up dramatically in the morbidly obese individual. So when it comes to talking about surgery, we need to talk about what if you don't have surgery? People worry about the risks of surgery. What about the risks of not having surgery? This risk of having surgery is far dwarfed by the risks of the obesity. So I keep saying overweight, morbidly obese, oh, how heavy is that? And that's where the BMI comes in, the body mass index. BMI, body mass index, is basically just a ratio of height to weight. So if you weigh 240 pounds, are you morbidly obese? Well, it depends. Are you 6'4" or 4'11"? So the BMI is that ratio. And the way these numbers came about is the NIH looked at populations, and they looked at, you know, at what weight do we start seeing a rising incidence of diabetes? At what weight do we see a rising incidence of high blood pressure? At what weight do people have less, does their lifespan reduce? So looking at those numbers, they came up with this stratification. And to give you an example, here's a slide looking at the risk of dying by virtue of the only variable being increasing weight. So as BMI goes up, when we hit a BMI of 40, the risk of dying today versus somebody with a BMI of say 20 or 25, which is a normal healthy weight, your risk of dying today is 4 times higher than that person at this healthier BMI. You see there's a little bit of an uptick at a BMI of 35. So the risks start increasing at a BMI of 35, BMI of 40, dramatic increase. You can change the title of this slide to the risk of developing diabetes, the risk of hypertension, the risk of cancer. The slides look the same. BMI of 40, there's a sharp uptick. And that's why the NIH defined morbid obesity as a BMI of 40, because at that weight, the obesity causes disease. Now, when it comes to that BMI of 35, where I said things start to increase, well, the NIH also defines that if your BMI is 35 and you already have a weight-related illness, diabetes, sleep apnea, hypertension, well, you've already shown yourself to be in that category of that risk profile. So BMI of 35 with a weight-related illness, you are also defined as suffering from morbid obesity. If you don't know your BMI, I have this little slide here. You can just go on Google, BMI calculator. But here's heights, here's weights, and BMIs. And in general, most insurances will cover surgery for patients with a BMI of 40, regardless of health issues, or a BMI of 35 with a weight-related illness. And some insurers will cover bariatric surgery for anybody with a BMI of as low as 30 if you have diabetes, because it is such a profound cure for diabetes. So what got us to this point? Well, unfortunately, this is a disease of the metabolism, and diets in general don't work. If we looked at 200,000 people with BMIs of 40 and put them on diets, how well are they going to do? 95% of them are going to be heavier within 5 years. And that's what the population studies that the NIH has performed have shown. Patients that are put in physician-supervised diets, exercise programs, behavioral counseling, they do well for about 6 months, but within 5 years they're heavier than they ever were. And you can see that with that TV show, The Biggest Loser. People lost a lot of weight. But if you look back, and this was published in the New England Journal of Medicine, if you look back at how did the people who succeeded on that show do, almost every single one of them is heavier today than they were before the surgery, before the show. The ones who have maintained their weight, most of them have actually had weight loss surgery to deal with the weight regain. Exercise, behavioral modification, medications, they do work, but at this level of obesity, they just don't work well enough. Like I said, there are some great medications that can cause appetite suppression and weight loss, but we're talking 20, 30 pounds. And in the patients that I am counseling for surgery, we're looking to lose 100 pounds to get the profound effects on health. Hypnosis, jaw wiring, acupuncture, the intragastric balloons, and Reshape Obera, they'll make you lose weight. But as soon as that device is gone, we've got the underlying disease. Appetite, metabolism, weight recurs. So anything that gets done has to be permanent. Surgical weight loss is not about making it harder to eat. It's probably the #1 misconception. This, again, is metabolic surgery. So wiring your jaws shut, yeah, you'll probably lose some weight, unless you're drinking milkshakes. And that's what happens is you start craving those foods that are easier to get down because they're more satisfying. That's why lap bands failed for many, many patients. Lap bands, an inflatable device that was put around the upper stomach, making you have a little golf ball sized stomach that would feel full. And if you overate, it was uncomfortable. In fact, if you overate a few bites too many, it came back up. But the problem is, it would come back up, you're still hungry, you sit down, you eat again. So that hunger drove you to continue to eat. Or you would change your eating behaviors to choose high-calorie liquids. I saw one patient not long ago who came in, "Doc, this thing never worked. I haven't lost any weight, but I'm vomiting all the time." And I said, well, how can you be vomiting all the time and not losing weight? What are you eating? She said, well, I don't eat anything solid anymore. I have about 14 yogurts a day. Well, all that calories, we just shifted what we're eating. That caloric drive is still there, but she was now taking foods that could go through and satisfy her. So we have to deal with that satisfaction. We have to deal with that hunger. Lap bands didn't do it. Jaw wiring won't do it. But the surgical procedures that I'm going to talk to you about today reduce the hormones that drive hunger. They do make the stomach smaller to some degree, so you do get this fullness, but the real reason they work is we're getting rid of the hormones that drive hunger. And what happens? Well, these surgeries are not necessarily designed to make you skinny. They're designed to make you healthy. And on average, we're going to lose about 60 to 70% of our excess weight. So sleeves, bypass, that's about what we lose. What does that mean? Say you weigh 300 pounds and you're supposed to weigh 150 pounds. You're 5'6" woman. Should weigh 150 pounds is healthy. If you weighed 300 pounds, you now have 150 pounds of excess weight. If you were to lose half of that 150 pounds, you have a 50% reduction in excess weight. These surgeries in general, you're going to lose about 60 to 70% excess. So an average would be going from around 300 down to about 180 pounds. That's average. 180 is not skinny. if you're looking to be skinny, that's not the goal of these surgeries. My goal is to get you healthy. We usually define success as losing half of that excess weight and getting a BMI below 35. Most of these procedures, sleeve and bypass, you lose that weight within a year. I will be talking to you about a procedure called a duodenal switch, or a SADI. That's a little more effective. It gives you about an 85% reduction in excess weight. And it does take about 2 years to lose the weight. And we'll talk about that. Some weight regain, totally normal. Usually 2 to 3 years after surgery, you're out of that honeymoon period, you're falling back into old habits, and some weight regain is normal. So the weight comes down and will bobble and then stabilize. With the bypass, 90% of patients will never regain the weight. The sleeve, 80% of patients will never regain the weight. The duodenal switch, it's closer to 95% of patients will have success. So we'll talk about each of these procedures. So again, here's some long-term results. This is gastric bypass patients. 15 years out, starting at an average weight of 340 pounds, getting down to about 180, 15 years out. This is stable weight, and over 600 patients just monitored over 15 years. The NIH has looked at the results of surgery and the risks of surgery and compared it to the long-term with obesity and the risks of obesity. And this is back in 1991. 1991, we were doing open procedures. There were no sleeves. There were no bands. There were no laparoscopic procedures, certainly no robotic procedures. We were talking about a higher risk procedure with poorer outcomes than today. But even in 1991, when the NIH looked and compared surgery versus non-surgical weight loss, it was a no-brainer. The safety of surgery was safer than the obesity left unchecked. The resolution in weight-related illnesses was far more profound. Patients who were being followed with just behavioral management, their diabetes got worse, their high blood pressure got worse, and they died 30% sooner than patients who had surgery. So people worry about, well, I don't want to die from surgery or a surgery-related complication. You are more likely to live longer with surgery than without surgery, because the obesity shortens your life expectancy. And without question, in numerous publications, life expectancy increases with surgical weight loss. So the NIH made the recommendation that if your BMI is 40 or 35 with a comorbidity, you should consider surgery. They do say you need to have some dietary education. You need to have tried diet and exercise at some point. You need to have some sort of grounding about what expectations are, and you need to have some level of sanity, stable, cooperative. You can't have uncontrolled depression. And what happens after surgery? We're not going to make the depression go away. If the depression is why you eat, and we've taken that crutch away, what else are you going to turn to? So we need to make sure that depression and mental illness is under control and consistent control. We need to make sure there's no addiction issues. Somebody who's got active alcohol addiction, marijuana addiction, cigarette addiction, that is a tip-off that you may not do so well with surgery, because if your eating behaviors are addictive behaviors and we take away your ability to tolerate food, you may just eat anyways. Even though you're not hungry and you are full, you may overeat and you're going to regain the weight. So we need to screen for those kind of addictive behaviors. And also, having said that, some of these procedures will unmask new addictive behaviors. We get rid of a food addiction, we don't want to shift your addiction to tobacco or alcohol. And we absolutely see an increase incidence of alcohol addiction post-surgical weight loss. And whether that's because of carbohydrate craving or because of change in the addiction psyche, it's not clear, but it absolutely happens. So that is a warning. Alcohol addiction, stay away from alcohol after surgery. And if you find that you're craving it, speak up, let us know, talk to me, talk to my program, so that we can intervene early with some tips to help reduce those cravings, even some medications that can help treat those cravings. I did add here on the bottom of the slide, some of our insurers, Connecticut, and a couple other insurers are now allowing gastric bypass for BMIs as low as 30, The gastric bypass carries a 55% long-term remission rate with diabetes. So here we're doing it not necessarily for weight loss, we're doing it for the metabolic effects to treat and cure diabetes. So if you're diabetic, the weight criteria is lower for some insurances. And certainly, even if your insurance didn't cover it, I would offer bariatric surgery for somebody with diabetes at almost any BMI, because changing how your digestion interacts with sugars, it changes your insulin levels, and it is curative almost immediately for diabetes in many patients. So the gastric bypass, I'm going to talk about 3 procedures, the 3 procedures that I do the most. Gastric bypass, this has got the longest track history. It's been around since the 1970s. It's undergone some different changes. I do all my procedures using robotic assistance, and I'll talk to you a bit about what the robotic device is and how it works. The bypass works by reducing the size of the stomach, but primarily by taking this part of the stomach, the main part of the stomach, out of the system. This is the part of the stomach where hormones, ghrelins, leptins, various different growth hormones, where they're secreted, and by getting them out of the system, we can reduce those hormones and reduce appetite. So here's where the metabolic part is. We're getting rid of this part of the stomach that has the hormonal drive. Now this kind of looks like a bunch of spaghetti right here. I'm going to put a little animated video up to help describe how the bypass works. So step number 1 with all these surgeries, we make 6 little incisions, sometimes fewer, and put these little plastic tubes in to give us access into the abdomen. Through these plastic tubes, we put some carbon dioxide to inflate the stomach. We put these instruments in, and through these instruments, we'll manipulate the bowel and do what we need to do. For a bypass, step number 1, we're going to divide the stomach and make the stomach, this part about the size of a golf ball. This part of the stomach is where the hormones are. We're going to keep the food from going through it. Because the stomach has been divided, it needs some way to have food exit it. So we come downstream here into the intestine, not very far down. We divide the intestine here. This part is going to swing up, so now food has a way to exit. And notice down here we're making a little Y connection. The blue is food going down. The yellow is digestive juices coming from the stomach, the liver, the pancreas. And at the Y connection, this is where what we call the common channel is. This is where digestive juices will mix with the foods. So undigested food comes down, enters into the small intestine. So we've got a small stomach. You will feel fullness. It's not like, oh, I had a big turkey dinner kind of fullness. It's, I think I might have eaten too much. It feels like something's getting stuck if you overdo it. So that slows down how you eat, gives you some satisfaction. That undigested food goes into the small intestine. Well, your brain doesn't get the memo that you've had a gastric bypass. Your brain is going, what is undigested food doing downstream in my small intestine? I must have eaten the entire chicken, not just the wing. Meanwhile, it's only that small amount of food, because it's undigested in that piece of intestine, that fools your body into thinking you ate more than you ate. And by having some of these hormones out of the system, reducing that hunger drive, the combination of those effects makes you feel full, makes you feel satisfied on a much smaller meal. These surgeries really don't limit what you can eat. There's some people who find, I have a little trouble with steak because it's too firm, and if I have a dry steak, I can't eat it. But I'll eat a filet mignon because it's softer. Good news is they only need a little small filet mignon. They save some money. Softer foods do go down easier, but we want you to eat solid foods. Can you eat a slice of pizza? Yeah, a year after surgery, you're going to have a slice of pizza, and that's it. You're not going to want the second, third, fourth. You're not going to go home with the pie. The slice is plenty for you, and it's satisfying, and you'll enjoy the flavors. You're just not going to want more because you're full. Most foods you can eat. The one thing you have to be careful with this surgery is concentrated sweets. If you have dessert food, ice cream, well, that concentrated sugar is going to have the same kind of effect. It's going to get into your intestine. Your body's going to think you must have eaten the entire pint of Ben & Jerry's, not just a couple spoonfuls. And it's going to secrete enough insulin for a pint of Ben & Jerry's, not just a couple of spoonfuls. So you'll actually can get an insulin reaction. You're going to secrete so much insulin that you're going to feel dizzy, lightheaded, nauseated. You're not going to want to eat ice cream again. This is called dumping. And that'll happen about 50% of our patients, that if you eat concentrated sweets, you will feel kind of crampy, nauseated, flushed. You're just going to go lie down. Some patients might get some diarrhea as well. The bottom line is concentrated sweets, you lose the craving for it. So dumping is a component of gastric bypass. It affects about 50% of patients where they get that full-blown effect. But usually within a year, that will subside. So dumping is unusual in the long term, but it is something to be aware of. And if you're somebody who just overeats sweets, this can be curative for you as sort of an aversion therapy, but it can also be problematic because if you start falling back into that habit, if this is a habitual or addictive behavior, then you might keep eating those things, and then we're going to have to deal with some hypoglycemic side effects. So that is a plus and a minus for the gastric bypass. And then the last thing with the gastric bypass is because this food is going directly into the intestine, it stimulates certain other hormones. One of them is called GLP-1. These hormones increase insulin expression, decrease insulin resistance, change how your liver processes insulin, and almost overnight gets rid of diabetes. About 80% of our patients, when we do a gastric bypass on a diabetic, about 80% of them will go home off of all their diabetic medications. Oral pills, insulin, etc. In the long term, some of them do require to be back on medication, but 55% of our diabetics are no longer diabetic 3, 4, 5, 10 years out from surgery. So this is curative for diabetes. So I showed those little holes going in the little tubes. Laparoscopic surgery has a stick and a little pistol, a little scissor grip for us to open and close the device. Robotic surgery is the same as laparoscopic surgery, except instead of having a scissor grip and a pincer, we're now changing it for sort of pulleys and wheels. There is no robot involved in robotic surgery. Instead, we have this little gantry that comes over the patient, and this is not our OR, because my patients in general do have heads. This is just sort of a mock-up of what the robotic system looks like. Usually I'll have an assistant at the bedside, a nurse, or a tech that's assisting them, and I will be at the console. Now, I start the surgery. I'm scrubbed in, I make the holes, I put the tubes in, I attach this robotic gantry, and then this gantry is attached to the tubes and the instruments. She's holding one here. They've got a couple little wheels that control the pincers at the end. And the reason it's wheels and pulleys is because it works in 3 dimensions. It allows rotation, open, close, up, down. It basically gives you a fully functional wrist and hand inside the abdomen. Why is that a benefit? Well, number one, it gives me more finesse. It lets the surgery happen on the inside instead of torquing these instruments and causing more muscular trauma. So robotic surgery has less discomfort than laparoscopic surgery, finer control than laparoscopic surgery, and added to that, at this console, the camera device is a high-resolution 3D camera. So it's like actually being inside the patient. So I can see better than I can laparoscopically. In fact, I can see better than I could even with open surgery. So my assistants will change the instruments as needed, and I don't need a lot of instrument changes. Once I've got everything attached, I will sit down right next to the patient and I will do the surgery. Again, there's no robot. I am doing the surgery. There is no big red easy button where I can hit the button, go out for a cup of coffee, come back, and the job's done. Fortunately for you, and not so fortunately for me. So this little video is actually me working at the console. Oh, we got some sound here. Let's shut that off. So this is me working in 3D. I'm actually sewing the intestine to that stomach pouch in a gastric bypass. And I'm picking up the instruments, picking up the needles that are curved, and I'm manipulating the tissue. And you can see it's sort of more of a finesse procedure than if I were using these large sticks. Inside, this is magnified tremendously by the visual system. what you don't get to appreciate with this is in surgery, I'm seeing this in 3D and high resolution. And you can see I've got a whole wrist and dexterity that I wouldn't have if I were just using this little stick instrument. And here I am sewing, this is the stomach pouch to the small intestine. And one of the things that I can observe here also, which I'll point out, so this is the small little stomach. It's going to be a golf ball in size. This is the small intestine being sewn to it. This intestinal connection right here is about a nickel sized in diameter. Here's the old stomach off to the side. You can actually see a little piece of staple here. These staples that we use to divide the stomach, they're triple reinforced. They're actually, this is only just about 3 millimeters in size, so that gives you an idea of how much this is magnified. I can tell this is a male patient because all this fatty tissue sitting on the stomach. Men tend to have this central weight distribution. You do a pinch test on a woman, you know, pinch the love handle, and there's a lot of, there's more commonly more tissue there to squeeze. The guys, they carry it inside the musculature. You pinch the skin, there's not as much tissue. So they may tend to be the apples as opposed to the pear shape. And all that fatty tissue then tends to be around the organs. And that's why men actually carry a higher risk of surgery than women do, because there is more operative complexity, because the organs are now bathed in fat, the tissues are thicker, they're less obvious that what we can see is what we need to see. So, yeah, let's move on to the next slide. So that's the bypass, that's robotic surgery. I do use robotic surgery to do the sleeve gastrectomy. Currently, in the last few years, sleeve has been the #1 procedure in this country. I don't think that's going to last. I've always been sort of a 50-50. I think sleeve is a great operation for somebody, BMI under 50, no health issues. But if you remember at the very beginning of this talk, I said bypass 90% success, sleeve 80% success. If your BMI is over 50, the success rates can drop as low as 20% with the sleeve. So for higher BMIs, I would not jump to this operation. However, the sleeve is actually designed as part 1 of a 2-part operation. And that 2-part operation, called a duodenal switch, is the most successful of them all, and also the most curative for diabetes. So that duodenal switch procedure, we can do in 2 stages. We can do a sleeve gastrectomy, and if you are one of those patients who doesn't lose enough weight, we do stage 2 a couple years later, which is not a very big undertaking, especially if you've had some weight loss. You're actually going to have maybe a little safer operation doing it in 2 stages. The sleeve gastrectomy works by removing that hormonally active stomach. Some people say, well, I'm kind of not comfortable with you removing a piece of my body for weight loss. If you had a diseased gallbladder, diseased colon, diverticulitis, a cancer, most people will accept the fact that removing a diseased organ is something you need to do. This diseased organ is causing your high blood pressure, your diabetes, your sleep apnea. It is compromising your health. This is a diseased organ. We're removing the diseased segment. So with the sleeve, we divide this stomach, we remove it from its blood supply on the outside here. The spleen sort of sits here. We separate it from that. And this is removed through a small little incision, same kind of incisions as you would have with a gastric bypass. We do put a little calibrating tube inside the stomach to calibrate how tight we're going to make this banana. So this little banana-shaped stomach. So you have a fully functioning stomach. It's just made very narrow. It gives you the same kind of fullness that you would get with the bypass, and it gives you the appetite suppression that you would get with the bypass, but doesn't quite have all the bells and whistles or the intestinal reconstruction that changes your blood sugars. So that's why it's not quite as successful in the long term. How do you feel after this? If I did a sleeve on one patient, a bypass on another, and didn't tell them which surgeries they'd had, they really wouldn't be able to tell the difference. Same sense of fullness, same reduction in appetite. You're not going to see the dumping quite as commonly with the sleeve. You can, but it's less common. The downside with the sleeve is that this tube, it's a fully functioning stomach. And there is acid secretion in that stomach, and this is kind of a high pressure system now. So as many as 10% of patients will develop some heartburn issues. So somebody with bad heartburn kind of want to stay away from this procedure. That means somebody who needs to take a pill every day or they're miserable. If you occasionally get heartburn, this is fine. In fact, 70% of patients who have this procedure and already have heartburn, it goes away just by losing the weight. I do some strengthening sometimes. People will have a hiatal hernia. I will fix that to help reduce the risk of reflux. But probably the Achilles heel of this surgery is that 10% of patients who will end up needing to be on lifelong acid suppressant medications. About 2% of patients may actually need this surgery to be converted to a gastric bypass to stop the reflux. Gastric bypass, curative for reflux. It's probably the best procedure there is. I said at the beginning, half my practice is weight loss and the other half is acid reflux related. The best procedure to treat acid reflux is actually gastric bypass. By dividing the stomach so that the acid secreting stomach is out of the system, connecting intestine to that's a low pressure system. That low pressure system and reduction of acid actually is over 90% curative for reflux in a gastric bypass. So somebody with bad reflux, bypass. Somebody with no reflux, minimal disease, lower weight, sleeve's a great operation. Bypasses, you can't take aspirin, Motrin, Aleve, it'll give you an ulcer. Sleeve, you can. Somebody with lots of arthritic issues might want to pursue a sleeve. So I said sleeve can be part one of part two. The duodenal switch, and I perform it as what's called a SADI or a SIPS, single anastomosis duodenal interposition. It's a newer modification of this procedure that's really reduced the long-term complications of what we would call a traditional duodenal switch. I'm not going to go into the traditional technique. I'm going to focus on this, my preferred technique. So here's the sleeve. Part two would be dividing that intestinal connection here, right past the lower valve of the stomach. So we divide that, it was connected here, and then, so the stomach used to come down, empty into the duodenum, then we would have 18 feet of small intestine, and they get to the colon. Well, about 30 centimeters before we got to the colon, we would make an intestinal connection here. So now food will go down this direction, digestive juices are going this way, and not mixing with the food until here. So the actual absorptive area is only that last 300 centimeters. This is enough to absorb your nutrients, but also attuned to not absorbing all of them. So if you had a very carbohydrate-rich diet, you won't absorb enough of the carbohydrates. What will happen is a lot of diarrhea. So this kind of forces you into a low carbohydrate diet. In fact, the people who have this surgery, we kind of end up eating more of an Atkins type diet. Very high protein, fairly rich in fat, very low in carbohydrate. But you don't come off that diet because your body doesn't accept more carbohydrates. So this yields the best long-term success, about 95% of patients having long-term success. It yields more weight loss. I said the gastric bypass, the sleeve gives 60% excess weight loss, the bypass about 70% excess weight loss. The switch here gives about 85% excess weight loss. So if we do a sleeve and you are still in a BMI over 35, you still have high blood pressure, or especially if you have diabetes, we can do this intestinal connection, divide here and connect, and you're going to, over the next 2 years, lose that additional weight. And this one carries about an 85% resolution for diabetes. So I think this is going to be the surgery of the future. I am already beginning to lean to this operation more and more, for especially if you're on insulin, this is the operation that I would go for. If your BMI is over 60, this is the operation I would go for in one stage. I know it gets confusing. There's 3 different operations I'm talking about. Which one is the right one for you? I'm going to put up a little flow sheet as we progress to help you kind of get this straight in your mind. But that's what I'm there for. When you come and meet with me in the office, I'll talk to you about each of these procedures. Why one might be better for you or worse for you. You come in saying, Doc, I want a sleeve, and I think it's a bad operation for you, I'll tell you. I'll tell you if I were, my BMI were 40, 45, and I had no health issues, I absolutely would do a sleeve. You know, that 20% failure rate, well, I'm in a lower BMI, so my chance of success is a little bit higher. And if I did not maintain my weight long term, I, as a surgeon, would be comfortable with phase 2. That's a big thing you need to have set in your mind. So we'll talk about that. So why the switch? Again, failures of the sleeve, weight regain. Again, I lean towards it with a BMI over 50 or poorly controlled diabetes. Same issues apply. If you have bad reflux, I'd stay away from the SADI because, again, it's a sleeve. Somebody who's a smoker, I won't do a bypass on a smoker. And then I would lean towards a sleeve or a SADI because smoking is not going to give you the ulcers that it would in a bypass. I kind of covered the rest of this already. The band, just a couple words, it's an inflatable band. I do not do these as first-line operations anymore. I do see a lot of patients for revision. Revision means undoing where the stomach was oversewn over the band, removing the band, and if we stop there, you're going to regain weight. It is working. Even though you may not feel like you've lost a lot of weight, it is working. When I'm revising, it's either for people who've lost inadequate weight, or for people who've gotten severe reflux, or for patients who've gotten severe motility issues, where this band has caused the back pressure, causing the esophagus and the stomach to dilate up, where you've got unrestricted reflux, and you also have loss of fullness because now your esophagus works to store the food like a new stomach. So in those situations, I'll remove the band. We need things to heal before we can go on to convert. If I'm doing it for inadequate weight loss where the anatomy is okay, or because the band has migrated, then I will very often do it in one stage where I'll take the band off and we can do a sleeve, a SADI, or a bypass. Now, yes, I can easily do a sleeve. It's actually easier to do a sleeve than any of the other operations, but in somebody who's failed weight loss with a band, I do have some reservations about converting to a sleeve because the failure rate is higher than the other operations. And who wants to keep going through failure after failure? It might be fine so long as you have the idea of, if it doesn't work, this is phase 1 of a 2-stage operation. Most often I'm counseling patients to go to gastric bypass after a lap band or a SADI. So again, this is something we talk about one-on-one regarding what kind of complications you might have with the band. About 80% of these patients I will do in one stage. About 20% we have to take the band out, let things heal, come back in 2-3 months to do the second stage. Anybody who's looking for a revision of a banding, most insurances treat you as a first-time operation. So you have to go through the same qualification process, dietary, psych, medical workup, that your insurance requires for first operation. So it can take 3 months, 6 months, depending on your insurance, to authorize a revision. With the weight loss comes improvement in health. Immediately we see improvements in that breathing, that restrictive lung disease I talked about. Exercise tolerance goes up. People feel like they have more energy. Sleep apnea, the cure rate is about 90% for most of our patients. I just had a patient yesterday who said, I need to get my ear, nose, throat surgery. They're going to open up my airway. Should I do that before my bypass or after? I said, don't let them near you. 90% cure for sleep apnea with this surgery. You won't need to have a very painful operation to remove your palate. So very effective at curing those respiratory problems. 70% resolution rate for asthma. Diabetes, we already talked about that. It's about a 30% remission for a sleeve, a 55% remission for gastric bypass, and 85% remission after SADI. And again, these improvements come immediately after surgery. High blood pressure, about an 80 to 85% cure rate for high blood pressure. Almost everybody's blood pressure improves. I can't think of a patient who's not had an improvement or reduction in their medications following surgery. GERD, we talked about that. 90% cure for reflux with the bypass. With the sleeve SADIs, we're looking at about 10% of patients who are going to have reflux. It may be new, it may be old, but 10% of patients will have reflux. About patients who come in with mild reflux, about 20% will be a little bit worse. And the other people who've got reflux coming into the surgery, 70% of them, it gets better. So it's kind of unpredictable. I do a preoperative workup that involves a barium swallow and sometimes an endoscopy, especially if you've got reflux, to kind of gauge what your risks might be. So I'll give you a little bit more information once we've done those tests about, what are your risk factors for reflux. I would say it's somewhere in the 5% range of patients who have a sleeve. They're really going to be that reflux is going to be a problem for them. And so we try to identify those ahead of time to keep that number minimal. If you have Barrett's esophagus, that is a precancerous state. So if you've had reflux, you've seen your doctor, and they've told you you have Barrett's esophagus, I, in general, do not consider a sleeve or SADI to be appropriate for you. A gastric bypass to cure the reflux and reduce your potential risk of progressing to cancer is what I would perform. Having said that, also, about 15% of patients, there is literature that suggests about 15% of patients who have a sleeve will develop Barrett's esophagus from chronic reflux, silent reflux. So I screen all my patients 3 to 5 years after a sleeve with endoscopy to make sure they're not developing this. And actually, I've not seen those kind of numbers. So while it is available in the literature as that high a number, I've not seen that. That may not be true with the SADI, because the SADI keeps bile from refluxing into the stomach, and bile is usually the cause of that kind of thing. So that may be unique to the sleeve. Cholesterol gets better, cardiac function gets better, arthritis gets better, the incontinence gets better. We talked about the menstrual issues. People feel better about themselves. This young lady, she went from over 500 units of insulin a day. She got a great Christmas card out of that. She wrote on the bottom, "This is a season to be giving, so I'm donating my old jeans to Santa." These are the pants she wore in on the day of her operation. By the way, she only takes 20 units of insulin a day, down from 500 units of insulin a day after her gastric bypass. So pretty profound result at 1 year. This is 1 year after surgery. So some other smiling faces. So how much weight you actually lose, there is a lot that depends on you. Follow up regularly. Like I said, we have a lifelong follow-up program. Probably about 20 to 30% of patients actually participate in that. About 50% of our patients, after about 2 years, they stop coming back routinely. There are some important blood work that needs to be watched, and especially if you do the SADI. The SADI you must follow up, because there are some significant nutritional deficiencies that can occur because of that intestinal bypassing. So the SADI is a really important one to keep long-term follow-up. Bypass too. The sleeve, yeah, you can be a little bit more independent on that, but without long-term counseling, I can tell you for certain the long-term results are not as good. So there are some eating techniques that we teach you. I'm not going to spend the time at this seminar to go over that. There is another seminar that our psychologist and dietitian does. That will go over proper eating behaviors. I mean, eat slower, eat less. Your body dictates a lot of this to you. That weight loss will occur. It is no longer about just being smart and choosing smart. Your body is going to help you with that. You're not going to fight your body anymore. We kind of talked about these numbers already. On average, the 80% excess or the weight regain numbers at 80% success with sleeve, 90% success with bypass, and with the SADI, 95% success. So risks. How scary is this operation? Well, we already said the obesity itself is more lethal than the surgery. Well, in perspective, the most common procedures in this country are colon surgeries, say for diverticulitis and colon cancer. The next ones would be gallbladder removal. The next would be hysterectomy. Those are the most common procedures. Where does, say, a gastric bypass measure up? And gastric bypass is the one everybody's scared of. Where does gastric bypass measure up in the risk? Is it as dangerous as colon or gallbladder or hysterectomy? Well, colon surgeries are the highest risk complications, 7 times higher risk of dying or having a major complication than a gastric bypass patient. Gallbladders, twice as high in terms of risk of major complication or dying from surgery than a gastric bypass. Gastric bypass is on par with hysterectomy. They are the safest operations performed in the United States. And this is based on Medicare, Medicaid data. Medicare, Medicaid publishes what complication rates there are for various different surgeries. And in Medicare, Medicaid population, which by the way are the highest risk patients in our country, the risk of a gallbladder removal is significantly higher than the risk of gastric bypass surgery. So we're talking procedures that have been very refined, being performed by surgeons who are specially trained at keeping that risk at a minimum. And at least with our program, a program that is involved in a national database overview where we know what our risks are and how we stack up to the rest of the country. So when you get worried about surgery or scared of surgery, think about, hey, if I don't do surgery, I'm not going to live as long, and I'm going to live that life with a poorer quality of life, and I'm going to have more health issues versus having surgery and having those issues improve substantially. And surgery shouldn't be scary. I mean, surgery is obviously scary, but keep it in perspective. If you had gallbladder attacks, and by the way, a history of diet, weight loss, weight regain, repeated weight loss and weight regain, that causes gallstones. You're going to be at significantly higher risk of needing your gallbladder out without weight loss surgery. In fact, weight loss surgery does tend to trigger gallstones. About 9% of patients may need to have their gallbladder out eventually. If I screened for patients who've got gallbladder disease ahead of time, many patients already have gallstones. We don't take them out unless they're causing trouble, but keep it in perspective. You know, my gallbladder is a problem, it hurts, get it out. Yet they're scared of doing a gastric bypass, which is safer and is going to improve their health and life far more significantly. They're scared or poo-poo that kind of procedure as cosmetic. So try to keep these things in perspective. Think about what your alternatives are. People are scared of dying from surgery. I've never had somebody die in surgery or die from the surgery. When it comes to risks, we think about who are you? What are the risks coming into the surgery? Now, obviously, the heavier you are, the higher the risk. And there's 4 main risks. Number 1, male or female, we talked about that. Men tend to have that more central weight, that apple versus pear. Number 2, your age. As age goes up, especially over age 55, the risks go up. But somebody who's 75 and morbidly obese is going to have a worse outcome than somebody who's 75 and has a weight loss procedure. So there's no age cutoff for surgery so long as you can tolerate surgery. So age, male versus female, your surgeon, you want to have a surgeon who's skilled, accomplished, and has their practice really focused on these procedures. And then the most important one is, what's your weight? The higher the weight, the higher the risk. Once we get BMIs over 60, the risks go up almost 10-fold higher than people with BMIs under 50. So what's the one thing we can do to make surgery safer? We're going to try and get you some weight loss before surgery. So we'll get you involved with our medical program, with our dietitians and counseling, and we try to get your weight as low as we can. Some people just can't get their weight down, and we accept that. We do surgery. But the more weight you can lose before surgery, the safer your operation will be. I can give you an example of a couple patients I've operated on. I've got a patient I did surgery on last week. She's 24 years old. She's got twins. Her mom is pretty much housebound from obesity and arthritic effects, and is really just a health mess. She doesn't want to be that way. She's completely healthy. Her BMI was 41. And she said, "Doc, I don't want to go that route of my mom, and I need to keep up with my kids." We did a sleeve. The sleeve surgery takes about 30, 35 minutes. She went home the next day. She's doing great. Then I had another patient I saw in the office recently. In follow-up, she would like a tummy tuck operation. I do some tummy tucks. She, when she first came to me a number of years ago, came in with her husband. She was in a little Johnny cart. She can't walk at all. He has to help her slide onto the toilet or slide into the bed. She can't bear weight. Her legs are about this large. She's about 4'11". Her legs, each leg probably weighs at least 70 pounds on their own. She weighed initially just about 400 pounds, sleep apnea, diabetes, on blood thinners because she's had a blood clot. She's got a defibrillator. She's got a pacemaker. She's only 40-something years old. How much longer is she going to live? We did her surgery a number of years ago. She comes in now. She uses a cane or a walker because she's got such horrible arthritis from all the weight and what it did to her. But now she weighs 155 pounds. She no longer has diabetes. She no longer has high blood pressure. She no longer needs to be on oxygen. She no longer has sleep apnea. And it's been, I think it's been about 7 years now since her surgery. She wasn't going to live another 7 years. So when you think about what are the risks of surgery, are you like patient number 1, where the surgical risks are so remote, yet the upside is there? Or are you patient number 2, where the risks are astronomical, but they still outweigh the risks of not having surgery? I can tell you, patient number 2, we had a serious discussion about, yeah, this surgery, very high risk. Yes, you could die from the surgery, but you're going to die without it. The death discussion, that doesn't really enter into the discussion for patient number 1. So you need to sort of stratify what your own particular risks are, and we'll talk about that. And I'll work with your cardiologists or pulmonologists or doctors to come up with the safest way to go through this surgery for you. Specific risks with the gastric bypass, the one everybody worries about the most is leaks. I've never seen one. I'll take that back. I've had 2 patients that I know of who've had leaks. That was over probably about 15, 16 years ago, back in the open surgery era. And those patients who had leaks, well, we put a little drain in, sucks the fluid. The CAT scanners put the drain in, suck the fluid out, and those leaks healed up. If you got a leak from this part of the stomach, it would be devastating. But the most common reason for a leak would be here, where the intestinal connection is. And these are usually able to be treated non-operatively. The risks, my statistics, that would be 2 leaks out of about 3,000 operations. Who's going to get a leak is probably the male who weighs over 400 pounds and diabetic. Those are kind of the perfect storm for somebody who's going to have a complication. Having said that, especially with the robotic device, I've never had a leak. These staples that we use to divide the stomach, triple reinforce it. At the end of the procedure, we actually put a little tube down into the stomach, fill this up with blue dye, and make sure there is no leaking. You saw how everything's so magnified on the screen here. I'm seeing it in 3D, and I look at every inch of that staple line and make sure it's perfect, or we don't leave the OR. So I think the risks of leaks is really overblown. It's very, very uncommon. It is possible. What are the instructions I give a patient? If it hurts, don't do it. Doc, can I go to the gym? Yes. When can I go back to work? As soon as you feel able to drive. I mean, in the COVID era, patients can work from home the next day. Energy is going to be down. So I usually say it's going to be about a week for working from home, 2 weeks for going back into the office. You're a firefighter. You might have to carry somebody from a burning building. Take 2 weeks. Take 3 weeks. Take as long as it takes until you feel comfortable. But these tiny little incisions, most people go home and Tylenol is all they need. And I do not put any physical restriction on. So do what you want, so long as it doesn't hurt. The other instruction I give is, if you don't feel well, I need you to call. You should feel great. A little tired, a little sore, but you should feel great. There shouldn't be any nausea, there shouldn't be any vomiting, there shouldn't be any fevers, there shouldn't be any chills. Any of that going on, you got to pick up the phone and call. So that's how leaks present. Nauseated, flushed, feverish, you just feel lousy. That's not normal, call the office. Strictures are probably the most common complication. They occur maybe 2% of the time, and that's where this intestinal connection gets too narrow. So it's made the size of a nickel, and it turns into a pinhole. That happens usually about 6 weeks after surgery. When that happens, we'll do an endoscopy. I'll put a scope down under anesthesia, put a little balloon in, stretch it, and that usually fixes it. They can occur years out. It's usually associated with ulcers. Those very often may require a surgery to sort of remove this section and do it over again. I've seen that less than 1% of patients. Ulcers, there's one of the biggest downsides of this. Aspirin products, even a single dose of Motrin can do it. I do allow enteric-coated aspirin if you have significant heart disease, but you must take an antacid as well. I've not seen anybody develop an ulcer from that. There are some anti-inflammatories that are okay. Meloxicam, Celebrex, which are prescription anti-inflammatories, those would be okay. But you cannot take over-the-counter aspirin, Motrin, Aleve, Naprosyn, ibuprofen, because they will give ulcers. And you can't smoke, because the ulcers occur here in the small intestine. Those don't heal, and they do have a risk of perforation. And when they do heal, they cause the strictures. Very challenging to take care of. So cannot smoke, cannot take those medications. If there's a question, we'll talk about it in the office. Bleeding. Immediately postoperatively, all these procedures have the risk of bleeding. The spleen is here. These are raw surfaces. We keep you on blood thinners. I mean, my biggest concern with any of these surgeries is blood clots and pulmonary embolism. A patient with morbid obesity is at a much higher risk of blood clot. So we start almost all of our patients on a blood thinner injected the night before surgery. You're going to go home on at least 5 days of twice-a-day injected blood thinners. We do counsel you and teach you how to do it. But a blood clot and an embolism, those are potentially lethal. We don't ever want to see them. We get all of our patients up and walking right after surgery. You're walking a mile a day. If you end up staying more than a night after surgery, you're going to be walking a mile each day. Why would you be staying longer? It's usually a little bit of nausea. Everybody gets a little nausea. If you get your stomach divided, you'll feel a little queasy. So nausea that first day, that might be a reason to keep you an extra day, just to make sure that that gets under control. But most of these procedures, it's just an overnight stay in the hospital. But having said the blood thinners, well, you're on a lot of blood thinners, and these raw surfaces, they can ooze, they can bleed. Once every year or so, we might have a patient where we might need to give a transfusion to get the blood levels back up to speed while we stop the blood thinners and allow the body to clot themselves. I've only had to reoperate on just maybe 2 patients who've had bleeding. Usually it comes from this intestinal connection. If that bleeds, it may need an operation. I think I've done maybe that twice out of the last 3,000 some odd patients. So those are the main ones. My biggest concern, blood clots and embolism. We avoid the staple line leaks by doing it right the first time. Strictures occur, but we treat it. Bleeding rare. Obstruction is the other last issue with the bypass. You know, there are some intestinal connections. If this were to twist or kink or turn, obstructions in the intestine can occur. It's about 2% nationally. My series is much lower. But if we ever got a blockage in the intestine, we worry about this stomach getting all distended and potentially even bursting. You get really sick. It is not subtle. If you had an intestinal obstruction, you will go to the emergency room because it's profound nausea and severe pain. We do a CAT scan. If you have a blockage, you need an operation to fix. Bypass and the SADI procedure, if you ever have abdominal pain with those procedures, you should see your bariatric surgeon. Your primary care, your gastroenterologist, they're not going to know what to do. In an emergency room, you want to go to some place where there's a bariatric program. So you wouldn't want to go to, say, your local hospital in this state. There's certain hospitals that don't have bariatric programs. They're not going to know what they're looking at on a CAT scan. You go to New London, you may end up getting transferred down here because L&M only just recently hired a bariatric surgeon, but they don't have a bariatric program. So if they're not on call, they're not going to have anybody to talk to. So the bypass and the switch, complex anatomy, obstructions are a concern. Again, less than 2%, severe pain, severe nausea. It would need an operation to fix the blockage. The sleeve, the biggest one that I'm worried about is the reflux, which we talked about. Bleeding, again, there's a lot of raw surface here that is a risk. We are removing the stomach from the spleen and its blood supply. So bleeding from there can occur and can be a little bit more profound, and that would happen usually the first night, which is why I keep these patients overnight. Strictures can occur just like in the bypass, except it's usually a narrowing down here where the banana just sort of kinks into like a hockey stick. And those kind of strictures are very tough to treat. It's not like we can balloon it open with a bypass. Most of those patients, I will try to balloon it, but about half of them will probably need conversion into either redoing the sleeve, or if we divide this stomach here, we can convert it into a gastric bypass pretty easily. Somebody with severe reflux, the best treatment, divide the stomach here, turn it into a bypass. There are some things where we can reconstruct a valve, a little mechanical magnetic ring we can put on called a lynx to treat reflux, but really the gold standard would be converted to a bypass. So that's the treatment for reflux or strictures. Strictures cause reflux because they cause the stomach not to be able to empty well. Hernias and wound infections, I've never seen them, but we do remove through one of the incisions. It's a little bit bigger than it is with the bypass. Most people will have a little bit of soreness in the right-sided incision. That's where the stomach comes out. There's a stitch in the muscle that's there to prevent hernias. But in theory, hernias and wound infections are going to be a little more likely in this procedure. When we do the switch or the SADI, and I say that again, switch, SADI, it's the same procedure. The number one concern is the diarrhea. If you have carbohydrates, you will probably have diarrhea. Most people, though, diarrhea is not an issue, but a small percent, less than 10%, chronically just eating too many of the carbohydrates. And it may mean that we need to lengthen that 300 centimeters into a longer digestive tract. That might compromise the weight loss, but it'll get rid of the side effects. So that does occur in maybe 5 to even 10% of patients. The other thing is you got to stay up on your nutrients. Fat-absorbing vitamins, the B's, the A's, those may not absorb well with the SADI, so you got to supplement. Bypass, sleeve, SADI, all of them, we want you on multivitamins, specific bariatric multivitamins, which have supplements of zinc and certain other minerals that you don't absorb well with these procedures. You need to be on a calcium supplement, and you need to be on a vitamin D supplement. Most people we also put on B12, and most people we do supplement with iron as well. We monitor all these things. Iron deficiency, we can see that not uncommonly, especially with the bypass, where you just don't have stomach acid that is needed to absorb these medications, to absorb iron. And then we watch for gallbladder issues, but if you've got a symptomatic gallstones, we'll take it out at the time of surgery. So here's kind of a little summary slide about my decision tree, about what procedures would I might lean to for you. So if you qualify for surgery, and in fact maybe that should be a BMI of 30, step number one, do you have severe reflux that requires a daily high-dose acid suppressant? If that's what you've got, sleeves are out of the option. We're going to a gastric bypass. So that's an easy one. If you don't have bad reflux, then it kind of depends. I said a smoker, I'm not going to do a gastric bypass. So if you're a smoker, we're going to go to a sleeve or a SADI. If your BMI is over 50, you're going to probably want to lean toward the SADI as opposed to the sleeve. But again, do it in 2 stages. Do a sleeve, and if it doesn't work, we can always do part 2 later. Some patients with a BMI over 50, it might make sense to go straight to the SADI. That's something we would discuss depending on what your personal preferences are. So here, comorbidities, you've got some weight-related illnesses, your BMI is over 50. If you've got insulin issues, all of these are sleeve bypass or SADI. Why choose a bypass over a SADI? You got reflux, I would choose the bypass. Or if you just want to have just a surgery that's more, I've done thousands of bypasses, done very few SADIs. I'm beginning to see more and more patients because of sleeve failures, and not my sleeve failures, failures from elsewhere. Those patients are going to the SADI. So kind of depends on your personal preferences. And again, we talk one-on-one about these options. I'm going to listen to what your preferences are. I'll tell you what I would recommend to myself or my family member if they were in your health situation. And nothing's really set in stone. When we first meet, we set the foundations. Usually there's several months of progress through dietary counseling, psychological evaluations. Insurance sometimes requires as long as 6 months of counseling before we do a surgery. So there's more time to investigate and learn and form an opinion about what procedure you might want to pursue. Rapid weight loss can cause some hair loss. It does come back. Anemia, I mentioned the iron deficiency anemia. Portal vein thrombosis, about 1 in 5,000 patients, I've never seen this, but 1 in 5,000 patients may get a clot in the blood vessels that drain the intestines. It is a potentially life-threatening complication. Severe abdominal pain, you end up in the emergency room. The CAT scan shows that we put you on blood thinners. I've not seen it. Maybe that's because of all the blood thinners I give around surgery that prevents it, but it is a possibility, more common with sleeves and SADI than it is with a bypass. On the flip side, the bypass, we've got the hypoglycemia issues I mentioned. Usually that's somebody who's just having too many carbohydrates and getting chronic dumping, and that tends to be with that addictive personality. It can be problematic, and I do have 2 patients in my career who we've considered reversing their bypasses for severe hypoglycemia. Alcohol abuse I mentioned. The progress through our program starts really with this seminar. We are going to meet and talk about your thoughts and what you've gained and what you want to pursue. After that initial meeting, and in order to do that meeting, you do need to register on my chart with Epic. There's some questionnaires that need to be filled out. After meeting with me, everybody will need to see the psychologist and dietitian. I will set up medical consultations if indicated. If you've got no heart disease, you don't need to see a cardiologist. If you know you've got heart disease, go see your cardiologist now. Get a letter of you will want your cardiologist saying that you're safe to have surgery. So if there are any recommendations, you can get that ahead of time. We don't need to, wait on that. But I will guide people through that. If you need a sleep test or some other kind of workup, we'll get that directed. We do support groups. Currently during the COVID crisis, it's all virtual, so there's Zoom support groups, which is actually, I think, probably something we'll be doing forever because it's very well attended, was more well attended than our live support groups. But if we ever get back to live support groups, we run those on a weekly basis, both pre-op, post-op, medical support, and surgical support groups. With surgery, we do the blood thinners. You have it up and walking. Most patients go home day 1. Somebody with significant coronary disease, severe sleep apnea, we might keep 2 nights. First 2 weeks, you're on liquids. The next 2 weeks, you're on purees, and then you advance to a solid diet. We see you bypass all these procedures. I see you at 2 weeks after surgery or just a phone call. The COVID, now we're doing phone calls, but it used to be we would be in the office at 2 weeks. You see the dietitian at 4 weeks. You'll see me at 3 months, and then we will transition, fall as well, into our follow-up program with Dana, my nurse practitioner, who will see you every 6 months for the next 2 years, and then yearly thereafter. We talked about the vitamins, the calcium, the B12, the iron. Most patients do, at some point, ask about tummy tucks. I think only about 5% of my patients actually ever I do tummy tucks and abdominoplasty, but many patients I refer to my plastic surgery colleague. If you have rashes or skincare issues, insurances do cover that, but it has to be well documented. I would not consider any cosmetic surgery until about 1.5 years after surgery when you have plateaued. You don't want to have plastic surgery and then lose more weight and now have more redundancy. We mentioned that. So this is my last slide. I will give a couple other, I think it's my last slide, yeah. Really, it's important to read, to research. Google works great. You'll find out a lot of things, and you'll find some things that may conflict with what I have said. Everything that I've told you today is based on peer-reviewed literature, the true medical facts. You go on Google, you're going to hear some people saying sleeve's the best operation in the world. Some people say bypass is the best. I've given you an idea of the statistics. It's up to you to go out, research some more, get some more just reality-based, this is what I've been through kind of experiences. Remember, all that's biased, but it'll give you a little bit of idea of what to be looking at and what to be investigating. Our support groups really help people understand what the surgery and life after surgery is like. That's why we have them. We do require at least two rounds of participation in our support group, so you can meet people who've been through the surgery and hear what their experiences are without the bias of the internet, where people are either complaining or overjoyed, but you don't get the neutral. So that's essential. And the support groups are not limited to just 2 participations. In fact, some of the insurances like Aetna and Anthem now require 12 contact points with our program. So you get 2 or 3 dietary visits, a psychology visit, a visit with me, 2 visits with me, 2 support groups. Well, now we're at 8 or 9 visits. Those other 12, really the best way to get those, participate in the support group. Join in on Zoom, hear what people have to say, come out a little bit better informed. In terms of insurances, if you work for a small business in Connecticut, you have lousy insurance. Connecticut has the worst insurance policies in the entire Northeast. Every state from Maryland on north covers bariatric surgery in their general policies, except Connecticut. It is not part of our Affordable Care Act plans, and it is not part of the general insurance plans in the state. However, if you have a large employer, 50 employees or more, they are eligible to purchase bariatric surgery coverage for their employees. Certainly, Pfizer, United Technology companies, Mohegan Sun, the state of Connecticut all cover it. Most municipal insurances do cover it. Medicare and Medicaid do cover it. Medicaid, probably the worst of the insurances because they make you go through 6 consecutive months of dietary counseling within the program. They make you go through a bunch of unnecessary testing with cardiology and pulmonary, but they do cover it. You just have to wait about 6 or 7 months to get your surgery. Anthem used to be 6 months of counseling required. They've changed that to the 12 touch point program. Aetna went from a 4-month program to the 12 touch points. Cigna currently, at the time of this recording, is 3 months of counseling, but I suspect they're going to go to that 12 touch point program as well. Check with your employer, your HR, to find out what your coverage is. My office will check it. However, if you don't have coverage, you can still make an appointment to meet with me. They don't cover the surgery. It doesn't necessarily mean they don't cover the consultation. The consultation, if you've got any weight-related issue, that's your diagnosis, and that way we'll get coverage for that consultation, and maybe we can come up with a plan for how to maybe get you coverage, or we can consider talking about the medical weight loss program and getting you into the medical weight loss program to at least give you some sort of help if surgery is not financially available to you. I do get questioned about what the cost for out-of-pocket surgery is, and it runs between $18,000 to $20,000 for all costs of surgery, anesthesia, and 3 months of recovery. Our dietary visits are free, and your preoperative consultations usually are covered by insurance, except for maybe the behavioral health assessment. So that's all I have to say. I know it was a lot to say. I hope I held your attention through the seminar, and I wish we were doing this in person because it's much more dynamic. I get to throw in a few jokes and make it a little bit more entertaining, but those were facts that I have to share with you, and I look forward to meeting with you in the office.